Hi, I'm Neil Vercel. I'm a board member of the Multiple System Atrophy Coalition, and I'm going to be moderating the live Q&A. I'm going to start here with question for several questions for Shannon, actually. What are your thoughts on the use of neuromuscular electrical stimulation to activate gut contractures for an individual who cannot activate his left glute activation, for example? The goal of activating contractures is to strengthen the glute.
Yeah, so as a therapist with any muscle that is impaired in contracting and firing, we actually do use NMES or functional electrical stimulation a whole lot. The only thing I would say for someone that's interested in it is making sure that you do see someone to help guide you on where to place the electrodes, how to set it up. There are contraindications to electrical stimulation, so we would need to make sure that you don't have any medical reasons that you cannot use it. And then the other thing we use it a lot for is activities while you're doing the stimulation. So for example, walking or standing. I prefer to use it in a functional activity as much as possible versus just laying there and doing it. But it's definitely a great option that we have a lot of success with for anybody that's weak or unable to fire properly. I would just recommend seeing a therapist to help you set it up and make sure that you're doing it correctly.
Thank you. Okay, next question I'm going to direct to Raquel. From the same questioner, actually asked, what are tips for saliva management, and also what are your thoughts on using a Camelback water dispenser? That's one of those hydration backpacks for an individual who has difficulty holding a cup and needs a straw to manage fluid intake to minimize coughing incidents.
So for saliva management, I actually refer to a neurologist. So Dr. Chitnis talked about Botox injections for saliva management. Something behavioral that you can do is reminding yourself to swallow more frequently, but depending on how much saliva is occurring, even that may not be successful. So speaking with your neurologist on your team if you're a good candidate for Botox. And then the Camelback options, I do see, like, from, a mobility standpoint, how that could be helpful. I would just encourage you to meet with a speech pathologist and have them observe you and give some feedback, and make sure that you are not gulping from that, but taking smaller sips to reduce risk of choking.
Okay, thank you. Next question, this will be for Sarah. What is pursed lip breathing, and how does it help conserve energy? Maybe you could do a live demonstration.
Yeah, absolutely. So pursed lip breathing is a technique that we can help ensure that we are fully expanding our lungs and recoiling them. It can be really tempting to start using our accessory muscles and getting a little bit short of breath. And so the idea with pursed lip breathing is that you breathe in through your nose for a count of 2, and then you breathe out through your mouth for a count of 4. And the position of those lips being in a pursed position as if you're blowing out a candle. So a very light and controlled way to help with retraining and ensuring that we are optimizing our pulmonary function. So by doing that, then we can be decreasing the amount of work that we're doing with our breathing.
Okay, thank you. Next, I think this will be for Dr. Chitnis. This is, did I understand that botulism, I'm assuming botulism or Botox, to help with the extreme postular problems I am experiencing? I lead with my head and have a bent posture. You're muted.
Certainly, this is something that can be tried. I would suggest that you consult a movement disorder neurologist, somebody who has experience in identifying, the right kind of muscles, because as you know, the botulinum toxin works by causing, weakness or semi paralysis. of the muscles that are contracting more than they need to. So the short answer is yes. I mean, certainly the bent posture, can benefit from these injections, but I would consult a movement disorder neurologist that has expertise in EMG guided injections.
Okay, thank you. And I think it's always a good idea if you have access to a movement disorder specialist. I think it's always a good idea to see that kind of professional. All right, the next question, I'm going to go back to Shannon. With my rollator, I lean forward when I get tired and walk too fast and can't stop. Any ideas on preventing?
Yeah, so I am not going to assume, but I'm going to guess that you present more with the Parkinsonism type of MSA. And I say that because that's a very typical Parkinsonism type of gait pattern. What happens, we tend to be weaker in our posterior muscles, which causes that forward posture. As the day goes on, those muscles that help maintain your posture fatigue. And then what tends to happen, again, not assuming, but your steps get a little smaller. You can't catch up to your momentum, and that's when you get that forward uncontrollable movement. The answer that, of course, is very typical that I'm going to say is you can very much so benefit from therapy because there are a lot of strategies we can help with that. Learning how to move bigger, so take longer steps, that requires a lot more energy, and it requires a lot more thinking with that, but it really does help. And then we can really give you exercises to help open your chest up, keep your posture back, help with your glutes. And then one thing that people tend to do is when they start to get that over movement, they keep going instead of trying to stop. Bring the rollator closer and reset themselves. So a lot of times I recommend keeping the rollator close and trying to stop moving for a minute and then restarting, because you tend to get going and then even can risk falling forward that way.
Okay, thank you. Anybody else want to add to that? Or should we move on to the next one? We can move on. Okay. I think this is for Raquel. I'm having a horrible time swallowing capsules. I aspirated my thyroid pill the other day. Any ideas?
Yes. So I will say all of the strategies that I'm giving are very general. So first recommendation would be, if you're not seeing a speech pathologist, to get a referral so that you can get that individualized assessment. But something that you can try, and an analogy that I use with the patients I work with, is you think about that pill in your mouth and you use regular liquids. It's almost like a rock in a stream. Mm-hmm. And so the liquids are just going around the pill. So you can try something like a thickened liquid, or embedding that pill in some applesauce or yogurt or something to help actually push the pill back and coat it. And then with swallowing, we're working with gravity. So adding a little bit of that weight, such as a thickened liquid or a puree, can then help to move and push that pill down. So those are some general things that you can try.
Thank you. Another reason to love applesauce. Yeah. Okay. Back to Shannon again. What causes the inability to extend the knees back and move the pelvis forward to stand up straight?
Yeah, so there's a couple possible causes for that. One is a lot of times with MSA, you can have decreased force production. So the ability to move in a certain time manner to get from point A to point B. A lot of people have a really hard time from that, like seated to about 45 degrees position of standing up. So being able to move quick enough to get up. And then the other thing that is included with the weak muscles in the back includes your glutes. So your butt muscles that help lift you up. If they're weak, then you are not able to extend up. That whole movement also helps you get your knees back. So it sounds like there might be some weakness in your legs and your glutes, and maybe a little bit of inability to produce that force to get up. So again, something that can be really addressed with therapy, but that it sounds like some weakness, and it's not uncommon.
Okay, thank you. So I don't have any more questions in the queue right now. Let's hear from a little more from the audience. perhaps actually, maybe I think we have Raquel, you have a question or Sarah, you have a question for another panelist.
Yeah, so
Yeah.
this question is for Raquel, our lovely speech pathologist, and I feel like we hear a lot about voice banking. We heard a question alluded to it earlier in another presentation. What are some ideas and tips that you have for people who are interested in navigating those services? When do you recommend those services? All that good stuff.
Good question. So voice banking, if you're not familiar with it, is where you can record your voice, either preset phrases or just customized phrases of your own that you want to preserve your voice. And I always recommend starting that as early as possible because it is a pretty extensive process. And the voice can become fatigued, volume can become lower. So spacing it out over a couple of sessions. And Model Talker is a popular program that I recommend for voice banking because they have great tech support. So I tell people I'm the communication expert. I am not a technology expert. So finding someone to help you with the technology side of things, but it can be a great option if you're thinking about preserving your voice and transferring that to a communication device.
Okay, thank you. I have another question from the audience. What specialist is best equipped to coach the caregiver about safe transfers? And that's whoever wants to take it, please jump in.
Shannon, I feel like
It depends. Yeah.
OT
I mean,
and
OT and PT both,
Mhm.
occupational therapy works a lot on ADLs. So they're going to work a lot on getting in and out of the tub, getting in and out of the shower, getting on and off the toilet. We can also help with that, of course. Getting in and out of a car, getting on and off the bed. I'm going to probably help with that a little more often. And then we also, as physical therapists, work on floor recovery. So if you fall down, how are you going to get up? How are your caregivers going to help you up? And that's something we work a lot on. So it depends on the situation, but PT and OT both can contribute to that. I hope that was helpful.
Yeah. Did you want to add to that, Sarah, or Dr. Chitness? I saw that you were about to say something, perhaps. No. Okay. All right. Well, we have about 7 minutes left. Looks like we're out of questions. We can wrap up a little early if you'd like. So wanted to thank the panelists. I'll drag this out a little bit just in case any questions come in. But I want to thank the panelists for engaging presentations and for some great Q&A. Actually, I think Raquel has a question about Botox for Dr. Chitness.
Oh, sure.
Yes.
So I just wanted to check and see if there are any contraindications or when a patient would not be a good candidate for Botox for excess saliva production.
Yeah, so it's a double-edged sword. While you are reducing the excess salivation, you could potentially be putting them at a risk of dysphagia, which they are already at a risk of. So I think you have to look at each individual patient. This is usually done, but not by myself, but by a ENT otolaryngologist. We are very fortunate. We have a neurolaryngologist at UT Southwestern, Dr. Leslie Childs, who has a lot of experience with this. So basically, I'll definitely get a baseline, modified barium swallow, see what is the degree of dysphagia that they have. If they are doing really well and salivation is a problem, then you can certainly it's risk versus benefits, but you evaluate that per each individual patient. There are two toxins. I'll say that myoblock is the one that we traditionally have used, which is botulinum toxin type B, but then Xeomin, which is one of the botulinum toxin type A's, is also FDA approved for for sialorrhea. So you just have to but one of the things I can mention is there are medications, oral medications, which can be tried. So the things that we use is Sometimes we can use, the same atropine drops that you use to dilate the eyes. You can put them on the tongue, and those are helpful. There is a oral medicine that's called glycopyrrolate or Robinil that we use. And last but not the least, we use one of those asthma sprays that's called ipratropium bromide. And so all of those can also be used, to basically dry out, and then as you or somebody mentioned, is it's important to drink a lot of water and swallow, because a lot of times in these patients, the problem is not always that they have excess salivation. The problem is also that they do not swallow the amount of saliva that results in pooling. So I hope I answered your question, in a roundabout way, but it's a risk versus benefit, really.
Great,
This
thank you.
is Benjamin Nguyen. I have some suggestion comments because I actually treat patients with excessive salivation. And again, like Dr. Chitna says, we always try to avoid medication when we can, so we're trying to minimize that. However, if the salivation becomes so excessive, and you can actually see them in the clinic, what I use is like Dr. Chitness mentioned, myoblock, because one of the side effects is it causes excessive dry mouth, so that works out really well. And again, I would only consider that if other medication is not helpful, but sometimes these patients are so miserable that I'm really consider do the injections. And one more thing that we have talked about the roles of inpatient rehabilitation. Now, because of the changing in healthcare environment, it's much harder to bring a patient in for inpatient rehab because they have to fail outpatient therapy first. But there are benefits from bringing in certain patients. So I would definitely keep an eye out to see if those would benefit from coming in, because in the past we have admitted patients for inpatient rehabilitation, and they did show improvement based on the score that we look at. Thank you.
Okay, thank you. We have about 3 minutes left, about 2 minutes left, actually, and a couple more questions here. What is the product name for the voice banking system? I'm sure there are several, but throw out a couple of names.
The most popular one is Model Talker.
Model Talker, okay.
Mhm.
All right, thank you. Next question here. I walk on my heels with my wheelchair. Any recommendations on shoes that are better for this use?
I'm from what I'm understanding that you're probably sitting in your wheelchair and using your feet to propel. If
That's what it sounds like, yeah.
Yeah, if that's the case, I always recommend tennis shoes versus dress shoes. Dress shoes are slipperier. But any comfortable tennis shoe. I will say the thing that can make that difficult is if you are scooted all the way back in the chair, you probably are slipping anyway, so you might have to scoot forward a little bit. But any comfortable tennis shoe for you is going to be the best option.
Thanks. And this is another OT/PT type question. Trunk rotation stretching was mentioned as being very important. This is the first time I've heard of this. Will you provide an example?
Sure, I talked about that a little bit. Sarah,
Yeah.
please jump in if you want to.
Sure.
Important in that a lot of people express limitations when they're rolling in bed, right? When they're turning to get something, or that's when they lose their balance. Trunkal rigidity is pretty common. So my example was the LSVT big program, which we use for Parkinson's. A lot of those movements in there incorporate trunk rotation. So I'll just show you one of them. One of the exercises includes a twist like this. That is not a direct stretch, right? But we're stretching with function. We're dynamically stretching the trunk. We also do some stretching called open books. If you Google that, you can find pictures of it. It's where you lay on your side and you rotate open. And again, that's to get that rotation. So making movement easier for you.
Okay, thank you. We're just about out of time. I do have a comment here from our very own Vera James, board member emeritus, who says, if you get stuck in place, is it better to wear shoes that slide? Actually, that's a question. So.
It kind of, I would say I don't love like slidey shoes, because then when you aren't stuck in place, are you more at risk for falling, right? Usually when you get stuck in place, it's a freezing episode. And there are other strategies we can use to break that up. Sarah, I mean, do you have anything?
I totally agree with you, love. Yeah.
Yeah. Any slippery shoes make me nervous that you would end up falling.
Right. Prevent falls. Okay. Well, I want to thank the panelists for your great presentations. I want to thank the audience for sticking with us all day. I know it's 5:00 on the East Coast. It's been a long day, and thanks for joining us, and enjoy your evening.